Honorable panelists and distinguished guests, Assalamu alaikum. I am Dr. Dewan Raza from National Heart Foundation Hospital and Research Institute. Now I'm talking how do you prepare a patient for CABG? Why we take preparation? If we drive a BMW car without brakes, there is a chance of accident. On other hand, we drive ordinary car with proper fitness, the chance of accidents are less. When a patient considered potential candidate for cardiac surgery, a comprehensive evaluation of their overall medical condition and comorbidities is essential. This includes detailed history and physical examination, which may identify cardiac and non-cardiac problem and their recent baseline investigation. We look for brief history. On history, we look for smoking history, alcohol, diabetes, neurological syndrome, vein stripping, distal vascular reconstructions, urological syndrome, GI bleeding, active infection, coagulation issues, current medication, especially antiplatelet drug and anticoagulants, drug allergies, previous cardiac surgery, or any interventions. In case of COPD patients, COPD have severe COPD patient, higher risk of pneumonia, prolonged ventilation, atrial fibrillation, deep sternal wound infection, length of ICU stay or hospital, and increased operative mortality. And elevated PCO2 is a significant marker for postoperative pulmonary morbidities and mortalities. Additionally, patients on home oxygen or with baseline PO2 less than 60 torr are extremely borderline operative candidates. In case of diabetes mellitus, diabetes is associated with increased postoperative risk of infection, renal dysfunction, stroke, and operative mortality. On neurological syndrome, approximately 10 to 15% patients requiring CABG have significant carotid disease. On vascular disease, history of saphenous vein stripping and or ligation or distal vascular reconstructive procedure using saphenous vein are alert the surgeon to potential problem for obtaining satisfactory conduit for bypass grafting. On physical examination, we look for skin infection, dental caries, vascular examination, heart, lungs, varicose vein. Review the patient prior and current medication is important. Particular attention should be paid to antiplatelet, anticoagulant medication, which should be either continued or stopped prior to surgery, depending on the clinical situation. These are the antiplatelet we usually used, aspirin, clopidogrel, prazolam, ticagrelor. We usually stop 3 to 7 days before elective surgery. Urgent surgery for patients with critical anatomy should usually be performed within a week of catheterization when antiplatelet effect may not have completely dissipated. Timing of surgery balance the risk of an ischemic event versus risk of bleeding, recurrent platelet transfusion. Clearly, surgeon should never be delayed if clinically indicated. These are the anticoagulant, that is unfractionated heparin, low molecular weight. We used unfractionated heparin, we stopped 4 hours before surgery, low molecular weight 24 hours before surgery. These are the laboratory tests we usually do for normal routine cases. Basic metabolic panel. Postoperative acute kidney injury is more common in patients with stage 3-4 chronic kidney disease, especially in diabetic patients. If the serum creatinine has increased, surgery should be deferred if clinically feasible until it has returned to baseline. An elevated proBNP level is a predictor of postoperative LV dysfunction. Preoperative medication, all anti-anginal medication should be continued up to and including the morning of surgery to prevent recurrent ischemia. Antihypertensive medication such as beta blocker, calcium channel blocker can be given preoperatively to prevent rebound hypertension. The following orders should be noted. Planned operative procedure indication surgery, brief summary of the cardiac catheterization data, results of laboratory test data, obtain surgical note, consent in chart, anesthesia note, consent in chart, STS risk score, Euroscore, confirmation of blood bank, cross match, and blood setup. This is the chart. Risk stratification can offer patient and their families insight into their real risk of complication and mortalities. Documentation in chart and informed consent discussion is mandatory prior to any cardiac surgical procedure. Thank you. Thank you all.